Okay. Introduction to ASL. What is actually ASL? ASL is a non-invasive MRI technique which is used for measuring brain perfusion without any contrast agents. Initially, this technique was introduced in 1992 in rat models, but it was not widely used in clinical practice initially because it was having a lower definition, lower signal to noise ratio. Hence, in initial periods, it was used only in the clinical and research settings. But as the technological advancements occur, it is now slowly getting incorporated into the routine clinical practice. Before going ASL, we have to see a little bit about cerebral perfusion physiology. The brain constitutes about 2% of the body weight, which is 15% of the cardiac output. Normal cerebral blood flow volume is 50 to 60 milliliter per 100 gram of brain tissue per minute, and gray matter has 50 ml per 100 gram of minute, and white matter will has 20 ml per 100 gram of brain tissue per minute blood flow. The gray matter usually has higher blood flow rather compared to the white matter. In conditions where it has been decreased to less than 20, we can start to have ATP depletion. And if it is severely decreased below 15 to 20, we can have like 17 to 18, we can start to have infarction. And in less than 15, we can have electrical activity uh, decrease. Why we have to measure perfusion? Perfusion is basically tissue perfusion delivers oxygen and nutrients and removes metabolic waste. So it reflects the metabolic state of the brain tissue and provides the functional status and information. There are two main methods by which perfusion can be measured in an MRI. It is DSC, dynamic susceptibility contrast imaging, and ASL. What are the advantages and disadvantages of DSE? DSE, it is the technique currently we usually use in our routine clinical practice where you give a bolus injection and do the rapid imaging and make a perfusion map out of it. It measures the parameters of relative cerebral blood volume, relative cerebral blood flow, mean transit time, and Tmax can be measured from this. And the pitfalls it can be altered in a patient, like in cases of calcification, blood products, artifacts, and leaky blood brain, and variability can be there in the software also. But what they found is in the brain, we can use our own water as a contrast agent. In ASL, the protons in the water are used as a endogenous tracer, and with the help of that, they make it to act as a contrast agent and derive the images. So what is the difference between ASL and DSE? In ASL, it is a non-invasive technique. You don't need any IV access, and it is ideal for pediatric patients and patients who have difficult veins. It has no risk of nephrogenic systemic fibrosis or contrast-induced side effects, and repeatability is high. You can take multiple number of times without any dosing concerns, and it provides you absolute quantification, cerebral blood flow values. But DSC also has its own merits, like it has high signal noise ratio, and it is very fast, and it gives reliable Tmax levels, values. So what are the basic principles of in doing an ASC, ASL? ASL uses radio frequency pulses, and it alters the T1 longitudinal magnetization in the protons in the blood. And it creates two images. One is a labeled image, one is a controlled image. I have a video to show them both. And labeling is a process by which you are tagging the protons, and difference between this control image and label image will give you the final perfusion map with which you can make. There are different types of labeling. In initial phases, this is called pulsed ASL, where one pulse will be given and the image will be acquired. The problem with it is this had lower energy deposition and lower signal noise ratio was present. Then came continuous ASL. They started to give continuous pulse and took the image. What was the problem with this method is because of the continuous energy, it had tissue heating. So the latest which is recommended by all guidelines is pulsed continuous, which is a hybrid of both. They give intermittent pulses and acquire the image. in which it has a both higher signal noise ratio and less energy deposition. And I want to explain about this concept post-labeling decay. It is the time between after you label, the blood needs time to reach the brain or signal of like area of interest. The time between like labeling and image acquisition is called post-labeling decay. And it can be varying among different age group populations based on the blood flow. In neonates, it can be up to 200 milliseconds. In children, 1500 milliseconds. In healthy adults, usually it is 1800 milliseconds. And in elderly, it will be increased because of elderly patients can have heart-related conditions, decreased cardiac output. So they need a more post-labeling decay time to capture the image. But usually what is recommended is between 1800 to 2000. But in some other conditions, 2000 to 2500 also is recommended. So this is the process by which how an ASL will be done. Once patient, first thing is we have to label the image. Blood labeling is done. Once, so the protons are going in the like in water. They are labeled with radio frequency impulses. After they are labeled, they are allowed to go to the tissue interest area where they will be transferring this magnetization. Then one image is taken. And without this process, another image is taken. That will be control image. And this is the label image. And image is subtracted. And this is compared with proton density image. And the ASL CBF map is created. So this is how a final image of a color map will look like. Red will be usually hyperperfusion. Green will be normal area of perfusion. And blue will be low areas of perfusion. Black will be absolutely no perfusion. So we have to know about normal patterns of hyperperfusion patterns, which can also be, which we have to know before interpreting an ASL. In ASL, normal ASL hyperperfusion patterns, we can have posterior cingulate and precuneus areas can show hyperperfusion because of default mode network, which can be active in these patients. And patients who are usually opening and closing eyes, they can have increased perfusion in occipital areas. So they can have occipital areas like this image, which is showing occipital lobe perfusion, but in a normal patient. And bilateral basifrontal regions also can have normal increased perfusion. In globus pallidus, we can have increased perfusion, and in watershed areas, we can have hyperperfusion patterns. And two concepts we have to know is what is post-labeling decay and arterial transit time. Post-labeling decay is the time which is taken like after you label, based on the general population, how much time it might take for that labeled blood to reach the tissue of interest. But arterial transit time is the physiological time for the blood actually to travel through that area to reach the interest. In a in a better way to explain, if we want to like in a railway, if you want to book a train ticket, if I want to go in a train, if the train will be return at 4 p.m. 4 p.m. is usual time where the train reaches. That is the post-labeling decay. But train always doesn't come at 4 p.m. It can come at 3:50 also. It can come at 4:10 also, 4:30 also. The actual time when it comes is arterial transit time. But the usual time, which is usual for that to come, is post-labeling decay. How is post-labeling decay is important is if you keep below that, it can show increased perfusion. And if it is after that, it can show. It is like post-labeling decay versus arterial. Post-labeling decay is operator defined time, madam. Like it is a technician who comes and like if this is the age, this is the cutoff. So I am keeping they change in that MRI. So that is the time which is, but arterial transit time is blood has to flow across the artery and come to that area. Actual time taken by the blood is called arterial transit time. This is the transit time, which is a physiological time. Labeling decay is a operator fixed time.
The blood reaches from the carotid, the capillaries, then reaches to the parenchyma. That time is that the bonus time, when the time for the arterial transit time. We are trying to measure the transit time. We are trying to match that transit time. The post time will be. The delay is we cannot actually measure what is the arrival time. It is still that based on the age and physiology, that the milliseconds or 2000 seconds. If this is not matching the arterial time, you will either see no symptoms where that signal is already gone from the parenchyma, or you see signal in the arteries. It's called arterial transit arteries. So this delay time is very, very important. And that's why we have developed multiple layers, so where we can multiple delays and compensation.
So what are the factors which can affect this transit time is vascular path length, where watershed zones will have longer transit time, blood flow velocity, where cardiac output, BP, vascular resistance can can affect the transit time, and tortuosity, branching and collaterals, stenosis, vasospasm, occlusion. All these factors can affect your transit time. And these are the
We think that common everybody has got the same. So depending on the hematopoietic also it can change, but in the clinical setting it doesn't matter. For the absolute measures,
and these are the artifacts which can happen during ASL. The artifacts can occur due to while labeling, while transit, or during reading of the image. During labeling, it is called ineffective labeling, where like you have labeled in a wrong plane or in a wrong position. If a patient, all patients with ASL imaging, the head has to be symmetrical and it should not be tilted. If any tilting happens, there will be a minor occlusion on that side, which can affect the flow. So head tilt has to be proper, and any objects which can affect the magnetic property of this labeling should not be present in between. Some patients with a tracheostomy or carotid, any objects in the carotid artery or dental implantation, in that side, if you do ASL will magnetize that area, and this will again affect the magnetization. Finally, there might be a signal dropout. And not only the blood has an pulsatile flow, even CSF has a pulsatile flow. Sometimes they can mistakenly get labeled, and which can lead to ring of fire artifacts. And in transit, they can have based on in patients who have given contrast with gadolinium and can have loss of spin labeling. This all I have images I will show. And arterial transit time artifacts, border zone artifacts, all this we will see now. And in arterial transit time artifacts is where due to decreased cardiac output, blood will take more time to reach the area of interest. In border zone artifact, there will be decreased blood flow in border zone watershed areas. In trapped, any like blood while going to there, any intracranial aneurysm, anything, if it is in between the way, it can affect the trap this ASL labeled images and cause trapped ASL signal. And venous blood also can sometimes get labeled, which is called a venous ASL signal. In reading, that can have severe head motion, can have artifacts, and stagnation of tagged spins can cause artifacts. And physiologically, occipital lobe hyperperfusion while eye opening can cause artifacts. So we will be seeing one by one artifacts. This is an artifact. If you see the ASL image, there is a hypoperfusion on the left side of the hemisphere. But this patient was having this pilot tube was there, which has affected the magnetic susceptibility of this patient, which has led to this artifact. This is the susceptibility artifact from this pilot balloon in the endotracheal tube. Second is, this is called a ring of fire artifact, where instead of labeling blood, it has labeled the CSF also. So CSF will acquire in this perimedullary areas. So it will appear as the ring. It is called ring of fire artifact. So instead of labeling, we have to just reposition it so that will get resolved. And this is the patient. ASL was done in a normal way. And after giving gadolinium, it was again imaged, which is showing no images because ASL affects the T1 relaxation time, and gadolinium is a T1 shortening agent. So because of this, image will get lost. This is the arterial transit artifacts. If we see this image, we can see there is an hyperperfusion in this patient. But in an MRI, it is showing a tortuous vessels are here. So the blood takes more time to travel through these arteries. So it appears as arterial transit artifacts. This is an arterial transit. It's a pediatric brain ASL where in 1000, if PLD is not adjusted, this is a patient with PLD of 15 to 1500 milliseconds, which is showing arterial transit artifacts. But this child has received a IV anesthetic agent. Because of that, the blood flow is a little bit decreased. So it is showing as arterial artifact. But after PLD was increased to 2500, the perfusion is almost normal. And this is the border zone sign where because of this patient had an ejection fraction of 24% and had a reduced cardiac output. So blood in the border zone areas will take more time to reach. So it is showing as a perfusion deficit in this area, showing as border zone sign. And this is venous labeling, which is showing in this area. This is because of labeling venous blood. And this is motion related spiral artifact. If patient moves, it can create artifacts like this. So we'll go one by one in neurological disorders. First is cerebrovascular disorders. In acute ischemic stroke, the guideline based is doing a CT perfusion, or if CT perfusion is not there, we can go for MR perfusion. But in some patients, we cannot give contrast agents because they might have contrast allergy or their renal function is very poor. In that cases, we cannot go for perfusion contrast imaging. In that cases, we can use ASL for seeing this assessment of the perfusion deficit. Here, like in contrast imaging, DWI flare mismatch, here we can have ASL DWI mismatch. DWI restriction is taken as core, and the corresponding mismatch hypoperfused area is taken as the mismatch area. And if it is more than this, it is indicates usually salvageable tissue. And how it compares to the usual dynamic susceptibility contrast imaging. In a study conducted by Zaharchuk et al. In stroke 2024, it was found that it has a 94% negative predictive value for excluding a stroke. And it had, by Boker et al., they have found that it has 88% agreement with the DSC for mismatch detection. And in patients with acute ischemic stroke, it was found the ASL with the MRI showed additional findings of 24.5%. These additional findings like hyperemia, luxury perfusion, and other findings were seen in 24.5% in acute infarct patients, and 7.4% without acute infarction had shown extra findings. Yes, madam. That is one limitation. I have slides, sir. I have slides.
Settle that. Suppose you are paying the patient for acute stroke imaging, but suppose the patient has pre-existing proximal nerve, which has come in the area of infarction. So your core imaging has shown the acute infarct area. Next is the salvageable area, the temporal area. So how does it happen?
If chronic occlusion is there, narrowing is that the patient is already prone to have susceptible artifacts, or arterial transit artifacts will be already there. So image will be mostly unreliable in these situations.
Because the entire area is still be still chronic.
Okay.
Now area perfusion is correct. but chronic can create fatigue. So we cannot appreciate it.
And in systematic reviews which have compared MR perfusion imaging with the ASL, they have found a moderate to high agreement with the DSC for detection of penumbra among acute ischemic stroke patients. But what are the limitations in using the stroke patients is where like a small cortical or subcortical lesions tended to appear as normal in this ASL imagings. And next one is arterial transit artifacts. The unique feature of ASL is assessing the collateral circulation in these patients. How collateral circulation will look like is peripherally, it will have serpiginous hyperintensity pattern, which indicates slow moving blood. And here we have a patient who has a left MCA occlusion. This is the infarcted zone and which is not showing any hyperintensity signals in the ASC mapping. But here we have a left M1 MCA occlusion in patient which is showing small infarct, but the patient is having this peripheral serpiginous enhancement, which is the arterial which is indicating slow moving blood, which is which is showing arterial transit infarcts. So how this arterial transit artifact helping in prognostic outcomes in ischemic stroke patients? Meta-analysis showing patients who had this arterial transit artifacts had better outcomes than patients who did not have. And ASL in transient ischemic attack, patients who this is a study which was conducted by Zakharchuk et al. Again in 2012. Patients who 76 patients who came with clinically diagnosed TIA underwent ASL and MR imaging. ASL was abnormal in 62% of the patients, which was much higher compared to the diffusion weighted imaging, which was positive in only 24% of the patients. And the most common abnormality was arterial transit artifacts. And whenever the perfusion weighted imaging was abnormal, almost 93% of the cases, ASL was also abnormal. Here we can see a patient who came with left upper extremity transient weakness. The diffusion imaging is showing no acute infarct, but ASL is showing a border zone, mildly increased hyperintense signals, and perfusion imaging is showing normal flow. And post-stroke hyperemia assessment, after in this study, which was conducted by Jothivannan et al., retrospective patients of 40 patients who underwent endovascular thrombolysis, who had MRI and ASL after 24 hours and 5 days after endovascular treatment was taken. And in this patient, the hyperemia was assessed, and hyperemia on 24 hours in ASL correlated more with the final infarct value, and it appeared to have it was appearing to have an important prognostic marker. This is the patient whose DSC was showing not much restriction, but ASL is showing hyperemia in the regions, and after 5 days, the flare images were corresponding more with this size of the lesion in the ASL.
So you want to say that ASL is superior?
No, sir.
That's beautiful.
And artifacts are too much there, so this can be used as an additional mode and like additional sequence rather than the primary sequence, sir.
It does the image, not an image, it's a parameter. It actually gives some possible division. That's what it might be grams per second. So that we are not visual only compare severe on basic vision, they are related. ASL as actually has got more specificity as far as execution is. The problem is that has to be done with multi-day AS. signal delay ASL can
Suppose you have an acute stroke patient, you don't have specific perfusion. Only a lot of this is available. It's technically open according to your suggestion. What the percentage of these?
DSC only has to be going for, sir, because DSC as a like it is more recommended, and as it gives a proper high signal ratio imaging, which can be correlated. But ASL has more artifacts and it has more time. It needs more time. In acute patients, there can be moving, and one movement can cause all the artifacts to come in this patient, which might make interpretation very difficult.
Multi-delay, the problem is multi-delay was so researching. So you have a lot of artifacts. Because now it's a problem, you know. So they have to know the things. Maybe more useful. But the real problems. World over nobody. These are all old papers.
Yes, madam.
Except in pediatrics. Please use. It's not that. It's not a
That's why we do this. They're going to talk for half an hour. Something which is not used.
And we can also see in ASL luxury reperfusion phenomenon. What is the difference between hyperemia and luxury reperfusion? Is hyperemia is establishment of blood flow in a salvageable tissue, whereas luxury reperfusion is the increase in blood flow in a dead tissue. So it is due to failure of autoregulation, which this luxury hyperperfusion can be a predictor of increased swelling and increased rate of hemorrhagic transformation. In this patient, we can see increased flow, increased signals in this region, which can is a sign of luxury hyperperfusion. And what about the ASL in arterial stenosis? It can, in carotid or proximal arterial stenosis, it can identify the tissue at risk for ischemia and infarction. This patient is a patient who has a chronic occlusion in this left internal carotid artery, and a FLAIR imaging is showing an no acute infarct, but ASL is done showing at hypoperfusion in that hemisphere of the brain, which is identifying this as a risk zone, and patient can be, risk stratification can be done and patient can be treated accordingly. And ASL in Moya disease, in a study which was conducted by Fan et al., 15 Moya patients with ASL and simultaneous PET imaging was done, and it was found that multi-delay ASL was superior to single-delay ASL, and when compared to PET and done, multi-delay ASL had 83% of correlation with PET values than the single-delay ASL, which has 73%. And long labeled long delay ASL improved this accuracy, because in a long label long delay there was no difference between the PET and ASL. And this is a patient with bilateral Moya disease. Patient with bilateral Moya disease, which is patient is having a blood. This is the standard ASL, which is showing perfusion deficits in this hemisphere. But when it is a multi-delay ASL, the filling occurs more, and we can see actually the area of low perfusion areas, which is almost corresponding, which is showing better than the PET scan.
Studies we need to define the parent the periods of coach. The same
here there is function. The time delay expenses that we can measure only the CBO, not the CBD.
CBV cannot be measured, sir.
Multi-delay, you can see that arterial transit time can be calculated. But that is more safe on the index or directly compared to see in the CBD or a mean transit. what we are doing is that if we don't have multiple delay, we are MRI disease, we are using multiple delays, we are using thousands of time, and see how progressively these areas are filled. And that will give an idea about which is the area which is having steel and which is in maximum amount of acute perfusion, which is the vulnerable area which can be perfused first. But that is not equivalent to cellulite channels. There that recapillary center has to be channels. That is not there. Yeah, no.
And in another study, which was done by Fan et al., which has showed 20 Moya patients with MRI, ASL, and PET imaging showed no difference between PET imaging findings and a multi-delay ASL. And this is a patient with bilateral significant occlusion in the left MCA, and which is showing increased arterial transit time in this the region, and SPECT is showing decreased perfusion. In a single delay ASL, it is showing a bigger hypoperfusion areas, but in the multi-variable delay, it is showing a filling.
Variable delay also can individually see the delay depths. So you get an idea how progressive delay also.
In CT perfusion studies, you look for the leakage reduction. CD reduction, CDF reduction leakage, 50% of the movement. What happens in bilateral there's problem? CT perfusion studies. So if you have to define what you say we are assuming as normal, then 30% of which is taken as a cutoff. Other say to define a particular situation. When bilateral is abnormal, there is a problem. The main problem is
One would push even more vested level because the relaxed CT is more accurate because it is for only one parameter. The amount of density of iodine that is uniformly directly related to the perfusion. Whereas this relaxivity is not linear. The access sometimes it plateaus. So it may not be accurate at all. The perfusion is the least reliable. That is perfusion as well as stroke is concerned. Perfusion is standard. Even then, it has got a lot of fallacies because of the assessing software. Based on software, you can have very, very good. That's why. That's a turnover. It is very few trials it has actually used perfusion. So everybody using automation, this thing. Perfusion as a parameter is very difficult to reproduce with the same software may be replaced, but with the different scanner, the different software is different. So everybody has told, all the trials have told that it has to, perfusion has to be optimized within the institution. That means you have to have developed your questions.
And cerebrovascular reactivity. What is cerebrovascular reactivity? Is the capacity of cerebral blood flow to change when brain physiology alters. In patients who have chronic cerebral hypoperfusion, vascular bed will be already dilated. This will not undergo further dilation with any medications. And this is an important biomarker for future risk. In this is a patient who has a bilateral AC and MCA occlusion. This patient is showing a pre-vasodilation. It is showing a decreased blood flow. And post-vasodilation with acetozolamide or dipyridamole or hypercapnic oxygen, it is showing the filling starts to occur in this area.
Dilates. So it can actually, once it dilates, can actually give more blood, and some of it will be stored up to the area where it started. But even here, for example, the right corner region, after acetozolamide, you can see there is no perfusion. That means that there is no flow happening there. That's the maximum dilation is happening. Further dilation is not possible. That is the area which is maximum.
the collateral perfusion, do you have an autoreproductive capacity?
Collateral. Okay. And ASL in seizures and epilepsy. Conventional MRI findings can be unremarkable in 20 to 40% of the epilepsy surgery candidates. In these patients, we can use dynamic cerebral blood flow changes to correlate seizure cycle phases, which can show hyperperfusion or hypoperfusion. The benefit is no contrast agent is required and it can be multiple times repeated. And ictal and periictal phases is during or immediately after a seizure. A study conducted by Schertz et al. Showed retrospective 25 patients who had a seizure underwent MRI and ASL. Lateralized cortical hyperperfusion was present in epileptic zone in all the patients. And this hyperperfusion tend to cross the vascular boundaries, which differentiated it from the vascular event. In vascular events, they were confined within the vascular territory. In the seizure patients, it crossed these vascular boundaries. And usually, in 32% of the patients, it involved ipsilateral thalamus, and in 20%, it involved contralateral cerebellar hyperperfusion was involved there. This is a patient who had a ICSOL in the left parieto-occipital region, which was after a seizure, he had increased perfusion in the same area. But when in this ASL, we can also see ipsilateral thalamus activation and contralateral cerebellar increased cerebral blood flow. This mechanism I will explain in the next slide.
It's post-ictal. So we have it in the intrictal.
Intrictal, I have slides, sir. And this is another patient who presented with seizures having increased perfusion in the cortex and ipsilateral thalamus hyperperfusion and contralateral cerebellar hyperperfusion. In patients who have seizures, there might have a thalamocortical activation. So this is a very specific finding for a seizure. If you see a patient with an increased perfusion, ipsilateral thalamic involvement, corticothalamic tract can be activated in this mechanism can be there. And this is called cerebellar diastasis. Oh.
Probably it is suffering sexual collapse, one of the regions of the event. To go through the whole article and don't give an impression that all the exits will be do this, the numbers exactly and opposites of the time. That is what it would do. They are very, very useful.
Yes, madam. Only 30% and 20% had this. Yes, madam.
What they have said that and the patients not acceptable learn. This is being given to one of the first year results. So I've gone through all articles. This just one technicality they have found, and that is what they've said that. But that you're going to click so that the all the persons are always will be the all epilepsy cases, and the lapis and nonsense that. There's something sensitive. Don't show the pictures and find them.
And in the same study, lateralized hyperperfusion was seen in all seizure patients, which had 72% topographic correlation with the EEG, and 91% had lateralization match, and 76% had lobar level match.
It's called poor man's spect. It's called poor man's spect.
Because when we want to see for perfusion, the hypoperfusion will be seen in interictal period, madam. That if your patients are in resource poor settings where PET scan cannot be done, ASL perfusion can. And post-ictal perfusion patterns in patients who had 21 in this study, which was published in Brain Journal, 21 patients with drug refractory focal epilepsy with ASL done within 90 minutes of the seizure, and interictal scan done after 24 hours of seizure was studied. In this post-ictal perfusion, reductions of more than 15 units were seen in 71.4% of the patients, and 80% of the patients had localized location of the hypoperfusion was partially or completely concordant with the presumed seizure onset zone. This is a patient with a right MTS. In this patient, the perfusion defects were confined to this right temporal lobe zone. Hypoperfusion was present. And this is the patient with presumed onset in their left temporal hypometabolism was present. In this patient, left temporal zone was involved. Hypoperfusion was present.
What is this hypertrophy? Is it a statistical man?
It's been. And this brain active is very important. That's it's mapping the threshold, not the confusion. Okay, go to the article and some know what is SPM.
And ASL in status epilepticus. Usefulness of ASL in initial evaluation of status epilepticus was studied in this studied by Kim et al. In this, 51 patients with status epilepticus and 46 patients with self-limiting seizures were included. In patients with status epilepticus, altered perfusion was seen in 90.2% of the patients in ASL. Compared with the DSE, it was seen in this altered perfusion was seen in only 39.2. In FLAIR, it was seen in 52.9, and in diffusion, it was seen in 35.5.3 patients. And thalamic perfusion abnormality was seen in 49% of the patients with status epilepticus. The accuracy of this was 75.3, and self-limiting focal seizure showed only a sensitivity of 50 to 74% in identifying seizure focus. And what about in patients with non-convulsive status epilepticus? ASL and EEG was done in 27 patients with NCSC presenting within 24 hours, and total 28 episodes were recorded. One patient had 2 episodes. In this, patients who had cortical hyperperfusion was associated with all NCSC episodes. In this, thalamic hyperperfusion was seen in 16 episodes, and this thalamic hyperperfusion had only a sensitivity of 76.2% and 100% specificity. And this is image of the patient. EEG is showing a bilateral rhythmic delta activity more in the right hemisphere. And in this patient, right hemisphere, we in occipital region, we have increased perfusion, and ipsilateral, this thalamus hyperperfusion we can see. Less than 2.5 Hertz rhythmic delta activity, sir. In In temporal epilepsy, in this study, they have compared 20 temporal lobe epilepsy patients. 9 had MRI positive and 11 were MRI negative patients, and which were compared with 14 normal control patients. Both groups, that is MRI positive and MRI negative, temporal lobe epilepsy demonstrated significant ipsilateral, mesial, and lateral temporal, mesial and lateral temporal hypoperfusion in hippocampus and anterior temporal neocortical regions. And MRI positive group had more significant asymmetry compared to the negative group. And in cases of Rasmussen's encephalitis, a retrospective analysis was done in our center, which saw patients between 2015 to 2017. 9 patients who were clinically diagnosed to a Rasmussen's encephalitis were recruited. In that, 7 patients had increased perfusion and 2 patients had decreased perfusion. In these 2 patients who had decreased perfusion, both had corresponding atrophy. And in patients with increased perfusion, hyperperfusion matched ictal onset zones in 6 patients, and partial concordance with epileptic form discharges were seen in 7 patients, all 7 patients who had hyperperfusion. And this is the patient who had and ASL in neurodegenerative disorders. What is the perfusion defects can accompany neurodegeneration. Even before the atrophy sets in, perfusion will be decreased in neurodegenerative disorders. This can be seen in this ASL, and it can be used for longitudinal monitoring of these patients. In Alzheimer's disease, usually we have hypoperfusion in temporoparietal cingulate cortex. In this patient, with normal aging, there will be an increased perfusion. But here we can see both bilateral posterior parietal regions, there is an hypoperfusion, which is more indicative of Alzheimer's disease. In frontotemporal dementia also, we can have decreased perfusion in the frontal regions.
On the hospital. So we have very rarely at that. So we have to send patient outside and get a test. That basically you should have answered. Now, absolutely answer must have been. So then scale some plan or just ancillary for suppose the patient with MCA comes. What do you expect it to be?
PET will have MCI will have decrease.
What is the ASL position?
In which one, madam? MC. Moil cognitive. I have a study, madam. I have slides for that. No, madam. I have slides. In minor cognitive impairment, also we will have.
If somebody expanded RFP for exam, it's reactive as well. Not really many names, but you only most tests. Now we are getting MCA, expanded MCA.
Mild cognitive impairment.
What did you say?
Minor cognitive impairment.
That could be your name. Answer the question.
It can also have hypoperfusion can be present in this patient. And ASL in mild cognitive impairment. This was study conducted in 2020, which compared 50 MCI patients with 35 healthy controls, in which ASL was compared with PET. And in this, it was found that the abnormalities were similar in both images, which particularly in the medial temporoparietal regions. And Pearsall correlation coefficient comparing both the values were very significant. And ASL is a reasonable, less expensive and safer substitute for PET scan. And we have in FTD and in Parkinson, we have diffuse decrease in perfusion. And for ASL optimization for neurodegeneration, older patients will have decreased cardiac output. So we have to go for longer PLDs or multi-delay ASLs. And PLD recommended is 2000 to 2500 milliseconds. 2 seconds to 2.5 seconds. ASL in brain tumors. ASL is like we want to know about vascularization and vascular proliferation. ASL can aid in tumor diagnosis and response monitoring and tumor types. In glioblastoma, in glioblastomas, we can have increased cerebral blood flow in that pattern. And how we can differentiate the glioblastoma versus primary CNS lymphoma is both will have same MRI characteristics, but glioblastoma will have increased perfusion and primary CNS lymphoma will have decreased perfusion. And in meningiomas, we will have a special sign which is called light bulb sign. This is a patient with a dural-based lesion, and because of his increased perfusion, we can have this. This is called light bulb sign. And brain metastasis can have both hypoperfusion and hyperperfusion pattern based on the primary histology of the tumor. And it can use for recurrence monitoring, WHO grading of meningiomas, and serial monitoring without contrast exposure. And miscellaneous uses, we have hemiplegic migraine. In hemiplegic migraine, like usual migraine will have aura, which can be visual or auditory. In hemiplegic migraine, during the aura phase, there will be a motor weakness followed by a headache phase. This motor weakness can last even for days, and it is a stroke mimic. So in aura phase, we have cortical spreading depression, which have global reduction in cerebral blood flow in the affected hemisphere. And in headache phase, we have trigeminal activation, which will release vasopeptides, which can cause vasodilation, and there will be increased hyperperfusion in this hemisphere. This is a patient, is a 79-year-old woman who presented with right-sided hemiplegia, gaze deviation, and aphasia. By ASL, we can see decreased perfusion in the corresponding hemisphere, but other imaging is showing a no acute infarct. This patient was later diagnosed to have hemiplegic migraine. And EEG was normal in this patient. And ASL also has utility in psychiatric disorders. And in ASL, we can have either two patterns. It can be hyperperfusion pattern or it can be hypoperfusion pattern. Hyperperfusion patterns can be reperfusion, recanalization, seizure during interictal, periictal, tumor, vascular malformation, and other areas. And hypoperfusion is seen in core penumbra, tissue at risk, and interictal seizure and poor cardiac output and vasospasms. What are the key advantages of ASL? It is very non-invasive, non-contrast requiring, and absolute CBF measurements can be done. It is safe for renal insufficiency patients, and repeatability can be done without safety concerns. And now the newer techniques are coming into velocity ASL and also specific artery labeled ASLs, which are improving more accuracy, and new techniques are coming. But ASL limitations, it has low signal noise ratio compared to DSE. It is very sensitive to arterial transit times and can miss cortical, subcortical, small acute infarcts, and requires optimization all the time for specific conditions and based on the age.
The arterial labeling is a technique. In order to this, or can there be any other application for ASL technique?
It is blood perfusion.
So, yeah, that would be the answer, let's say, reported last week. So, they go.
One simple question. These things. Whether how you ASL image is obtained. They're subtracting the control image from the base or the base image from the
Control image, sir. Control image is like we subtract a labeled image from the control image.
each one. It's just the most control or the
Most signals is in the control image.
so it would be a very minor part, 54% of signals. You are
Yes, okay. And now technical learning. Jody, you just move to one side. Yeah.
technique slide.
I have.
Reduce a seizure management of this. Not this.
This one.
1 second. Yeah, this one.
This one.
So what we use is that first thing is that ASL can have a multiple artifacts. So you have to position the patient in the neutral position. You cannot actually tilt this bar. This is the bar where you are actually tagging the blood. So both the carotids, patients should not actually turn the head also. If you turn upside down, one carotid circulation will be more than the other one. So you have to be exactly neutral position. The AC-PC line should be parallel. The problem with when the patient is under anesthesia, most of the time it will be extended. And you cannot actually tilt this not because technically it is not possible, because the vendors have actually blocked it, because as such it has got more, it has to be standardized. It is prone for more artifacts. So when you do this, at least 1 to 2 centimeters below, ideally 2 centimeters below the lower border of the cerebellar vermis. And what you're doing is that you're tagging both carotids as well as the vertebrae. And we know that the circulation time, and based on the circulation time,
approximately anticipated circulation time, we measure the we set the post labeling delay. So what we are doing is that we are doing this multiple pulsed ASL adiabatic pulses we are giving. It will actually shorten the T1 shortening of the blood. And when you have a without any adiabatic pulse, this base image, proton weighted image has got more signal compared to when you are actually shortening this when you are applying this adiabatic image. Though the control, I mean the labeled image is actually subtracted from the control image, you will get a small percentage increase in signal. This is almost coming in the scanner noise level. So you have to do it multiple times. It is not that one time you do and then you have to do multiple times. That's why it takes almost 4.5 to 5 minutes. That's why it is not very useful for stroke imaging. It takes more time than DSC perfusion. So the problems is that if you tilt it, there can be spurious increase or decrease. If you turn to one side can have more perfusion or less perfusion depending on the time delay. So this is what you are doing. The same thing, because of the same thing, you are if you are doing perfusion, after doing a dynamic perfusion, you decide an ASL, it is not possible because you have already given contrast. You have shortened the T1 of the blood so low that it will no longer you can actually measure it. So it has to be done before injecting contrast. Very important thing is that there can be spurious increased signal anteriorly as well as posteriorly, especially the posterior cingulate. Especially the posterior cingulate where the default mode areas, as well as patient when the patient is blinking or open the eye, it can be occipital hyperperfusion. Because of that, this may not be very useful for differentiating between diffuse Lewy body disease, Alzheimer and all. So patient, if they are measuring, you have to keep the patient, keep the eyes closed, and you have to do it in the neutral position without any head tilt, and lot of parameters has to be observed. Many a times technologists will not be very careful. Radiologist has to sit there and actually do this. And even then, some patients, it will be not possible. So we should know the limitations. We have published an article on this, and which I have shared with him. You can read that. So how difficult technically it is compared to DSC perfusion. No, control image also has to be acquired. Same parameters without that adiabatic pulse. For each patient, it has to be. That's why it takes 4 minutes, 4.5 minutes. It is not a cumbersome, provided you have to make sure that you are observing all these things. It is not a very simple thing. For example, that this thing, no, this this we have observed for the first time because this patient had come for localizing, lateralizing the seizure. So we saw that one whole hemisphere is low perfused, and when we coronal images, it was an anecdotal observation. We did the coronal images. This is a CSF labeling. Because of seizure, CSF labeling cannot be lower on the other side. Then we understood that there is some problem. And what this after intubation, now this pilot tube has got a very small aluminum spring here, which is MR compatible. But this, when after inflating, the anesthesiologist will throw it to the side. That is a usual practice. They will just throw it. But even then, this small thing can produce significant susceptibility artifacts, so that whole perfusion labeling is taken away from that side. So this was anecdotally observed, and we have actually wanted to prove that, and we taped on the center, and you see this artifact is. So it is very technically demanding. Unless you are very careful, can induce a lot of artifacts, and also the scanner homogeneity, everything has to be properly maintained.
Can you go back and see whether it's an artifact of
it is really difficult. Many times it is really, in this case, we could actually see the CSF labeling. That's why we understood that is an artifact. Otherwise, nobody usually will, because usual MR imaging, this spring has no significance. So we published this in that article on artifacts. So Another thing is that this jugular, sometimes it will come. And you tend to misinterpret as an arterial venous connection here and as well as a jugular, dural fistula here. So dural fistulas can be missed if you don't. But the problem here was there was a physiological narrowing of the distal jugular vein. So because of that way, with every valsalva, every breath, the venous reflex was going up. Most of the patients it can happen. So if you're tagging it that plane, even that venous signal can come. What you can do is that you can actually increase that tagging plane little up. This will disappear. So all those things, technically it is very demanding. And this is the, we had not a very good scanner as well as 3T is concerned, but only good thing we had that 3D pseudo-continuous ASL with the FSC readout, and which only the G had that time. This is the ISMRM recommended sequence. You see all the Saharchuk article supposed to be maximum published on. This article has got very bad ASL images because it is not our sequence. Our sequence is really good, but the problem is it is prone for lot of artifacts. This is from the review article. And this is called a smearing artifact, which is again when there is actually along the C direction, that is the superior inferior direction, there can be a smearing artifact, which should not, again, if you look at only the axial images, you think you will think that there is some focus of hyperperfusion, because axial it will look like one area of hyperperfusion. You have to reformat and see whether it is an artifact. This is called a smearing artifact, which also we have. This is a lot of physics explanations are like that. Gibbs ringing is producing this. We had a tussle with Saharchuk. He gave an entirely different explanation for that. But his explanation, I don't think it was correct. But this is a very useful technique, but at the same time, it should be, you should see this. If you see this, you cannot actually say that this is a, to differentiate, for example, this is an important sign to differentiate Lewy body disease versus Alzheimer's. So this can be spurious perfusion there. That's why PET is still a standard. But what is the real difference between ictal SPECT and ASL is that ASL, when you if you inject very fast during seizure, your radio label tracer will go and bind with that epileptogenic zone. You can image later. Still, that localization will be preserved. Whereas ASL is a dynamic thing. ASL, there is no binding. So as that Jacksonian march happens, when there is the what is that called? Hemodynamic response function changes with the electrical activity. There can be spread. So most of the time, so you can see a march and you will not be seeing the actual site of epileptic zone. You may be seeing a march. So you have to be very sure. It will be usually have some lateralization value, but not exact localization value. Cisco. Expect and subtract. Apply, yeah. So the same thing, if you do it in ictal and interictal ASL, may not work. It may not correspond with the Cisco. May or may not, because depending on that, when you catch it.
But we need to understand that there is a lot of anti-theory unless you know all the artifacts.
For example, DSC perfusion, if you tilt the head and all, you can still manage. Measurement will be correct because it has got an arterial input function and a venous outflow. There is nothing here. We cannot actually control any other parameters other than the post level.
Thank you. Thank you.